my name is John Hollingsworth. Today we're going to go through a brief video example of how to examine a knee. Our subject today is Claire, who's got a problem with her right knee. Before we commence the video, Claire's given consent to this examination and I've washed my hands. First thing I do is examine the gait of the subject. So looking from the side, I'm looking for any discrepancies in leg length. I'm looking at Claire's heel strike as she walks along. Is there any obvious antalgic gait? On standing, I can look for any swellings in the popliteal fossa, indicative of maybe a Baker's cyst if there was one there. And then from the front, I can assess as to whether there's any valgus or varus deformities of the knee. From that, I'd like to more closely examine Claire's knees on the examination table. Now, the important thing with any examination is symmetry. So, for time, I'm only going to examine one time, but you would always compare sides to see if there's any difference in ligament laxity or appearance of the knees. The first thing is just to have a quick look, and there's always some giveaway signs that might be previous arthroscopy scars, previous open surgery scars, or maybe some more subtle signs, maybe some wear and tear of the soft tissues and skin on the surface, where there might be an indication of some erythema or a prepatellar or infrapatellar bursitis. Looking at Claire's knees, clearly there's no scars here, and I can also roughly assess from looking whether or not there's any effusion or hemarthrosis, and that's because she still has a defined kneecap and there's still has the maintenance of the dimpling on the other side where the joint isn't pushing out to fill that space there. We then go on to palpate the knee, and we're also looking, as we're coming down, we're feeling for quadriceps tone here, we're looking at the muscle bulk, is it equal on each side? And ideally we'd measure the circumference of both quadriceps and hamstring complexes at a point about 20 centimetres from the tibial tubercle, which is here, and that would give us if there was any asymmetry. Moving down with palpation, I'm just running down, just feeling for any heat within the joint, which might be an indicator of an inflammatory or an infective process. Now, as I've got to the joint, I can feel the kneecap here. I would try and milk up any fluid that might be within the joint as it would come, and sometimes you can blot the patella onto the fluid beneath and it just pops back underneath your hand. There's no effusion here, so that's not going to happen. Presence of an effusion versus a hemarthrosis is important to distinguish. A hemarthrosis happens virtually immediately after an injury and is far more indicative of serious intra-articular pathology. An effusion might just be an inflammatory response and occur more slowly. As I'm feeling, I'm just seeing the alignment of the patella here. Is it in alignment? I just give it a little push laterally. People who recurrently dislocate their patellas will get particularly apprehensive with that. So it's good to look at somebody's face when you're doing that just to see if there's any problems there. There's no problem there. It doesn't maltrack, it's not fixed in one position. You can see it just track out laterally there, and that's a normal tracking of the patella in between my fingers. I then run my fingers down the ligaments which tend to become injured. The medial ligament runs along this pathway here. Tenderness right on the joint line can be indicative of a medial meniscal injury on that medial joint line. Higher up, more indicative of medial collateral ligament injury, and lower down maybe a bursa problem with the pes anserinus there. Similarly, I'm going to run the finger down the lateral ligament complex and see if there's any problem there. Now, having ascertained that there's no pain or anything there and no obvious injury, we can move forward to seeing if Claire can move her knee freely. Could you see if you can flex your knee right the way up and then run your heel up to your buttock? That's good. And then you can see full level of flexion, and if you can extend outwards again. Any pain on doing that at all? So there's no pain and I couldn't hear any clunking. What I then like to do is just actually repeat that with my hand then over the patella, and as I do that I'm feeling for any crepitus or grinding beneath the patella, any clunks or clicks. And at that point we can then put the knee roughly in this position, and then we can do some ligament examination. So the first thing while we're here is look to check out the posterior cruciate ligament, and sometimes you can see a clear sag here underneath the level of the tibial tubercle as the tibia is sagging backwards because the posterior cruciate isn't supporting it. And then we can just test that just a little bit further with a stress test, pushing that forward, and you'd feel that move backwards as the posterior cruciate wasn't holding it. There'd be no firm end to it. Here Claire's tibia doesn't want to go any further backwards than that. Likewise, we can look at the anterior cruciate ligament here. Now, the anterior cruciate ligament, there's 2 or 3 tests that we can do for that, and one of the easiest ones to do, certainly in this position, is the anterior draw test, and where we stabilise the foot on the bed so that it's fixed in position, and then we try and rock the tibia forwards, and an anterior cruciate ligament, if it's gone, will just allow the tibia to drift forwards, and again there's no clear end point to that. Claire's got a good anterior cruciate here, so there's no drift forwards. I'll do another couple of tests later on for the anterior cruciate, but it's just good to ascertain whether there's any other ligamental injury before you go into some of the more advanced tests. For the medial collateral ligament, it might well be the tenderness that we associated before, and to test the stress on the medial collateral ligament, we'll just apply a valgus force. So I'm pulling her ankle down towards me while pushing the knee outwards. That's putting a valgus force, that's in full extension, and then just pull it up to about 30 degrees. Do the same again. I'll compare both sides, and any difference between the two will be relevant. To do the lateral, it's a reverse, and we'll do, because we're already here in this position, we'll do the slightly flexed first, and then you're putting a varus force, which is just trying to open up the ligament there, and then again we'll just go down to that position, and then try that again. Okay. So, now we're back down in this position. Another test for the ACL is to stabilise the femur here and to pull the tibia upwards, and again this is Lachman's test. It will move forwards if there's any laxity there, and it would just not really seem to stop. It just keeps on gliding, and there's no ligaments snapping it together. Again, people's ligaments, so I would do that on the other side. The final test that I'm going to show you today, there are lots of tests, is the pivot shift test for the ligament. We just hold up the leg at this sort of angle, about 30 degrees. We internally rotate, and then as we flex the knee at about 20 degrees, you'd feel that just clunk upwards as it just releases. There's no clunking upwards there at all. Okay, so that's the anterior cruciate ligament. We've talked about the posterior cruciate ligament. We've talked about the 2 collateral ligaments. One of the main injuries that we see are meniscal injuries. And the menisci act as shock absorbers between the 2 femoral condyles. So you've got a medial meniscus and a lateral meniscus. To test the medial meniscus, what you're trying to do is nip that meniscus between the tibial plateau and the femoral condyle. So we've hyperflex the knee, and we'll externally rotate the tibia, and then we'll just apply a valgus force with my fingers on the joint line. Now, as I then flex that down, a clunk associated with pain would be indicative of a medial meniscal injury. To do the lateral meniscus injury, it's the opposite way round. Internally rotate, and that varus force, and again my chest. See. Now a lot of people then combine rotation with that as well, just to see if they can get that to grind or clunk or click, and you can do that in both ways, just giving it that force, and again there's no clunks or clicks there at all. So there you have it in a nutshell. That's how to examine the knee quickly. What you have to remember is in the acute phase, many of these tests will be painful. They're very, very non-specific. So a lot of these advanced tests, the for somebody who's got a chronic problem for a while. If you go in and do some of those tests like McMurray's on an acute injury, it's going to be painful. So don't be misled by positive signs if you're doing them at the wrong time.